5 children, ages 12 to 22, and are in the process of adopting a 13-year-old. Krista has an undergraduate degree in community health education from Brigham Young University. She later decided to go into nursing and obtained a degree in nursing from the University of Virginia. Still later, she returned to school again and graduated from the University of Cincinnati's nurse practitioner program in 2017. Krista worked 3 years as a primary care nurse practitioner in Canton. She saw firsthand the many barriers to accessing affordable health care, especially for those with no insurance. She decided to become a part of the solution and opened Affordable Healthcare Partners in February of this year in Wooster. Krista's business is a primary care medical clinic dedicated to the principle that everyone deserves access to high quality, affordable health care. Today, Krista will talk about increasing access to health care for the working class, barriers and solutions. Please give a warm Rotary welcome to Krista Michener.
That's all right. Yep. Can you hear me?
Are you a little shorter than?
I'm a little shorter than the average bear.
Yeah.
We could probably just turn this.
Hey guys.
I may have had to do this before in my life.
Hey.
That good? Okay, great.
Oh, man, we are.
I would like to add that BYU is also undefeated as of this weekend, so we'll just throw that in there. So I don't think it's difficult for any of us to see in business or as citizens when there are problems, and obviously healthcare is a huge problem. It's a huge problem being addressed in this election and every day. My work in nursing, though, has helped me to kind of have a firsthand view of how that impacts people and families on a personal level. So I've spent a lot of time researching and addressing these problems and wanted to bring some of them to your attention, some of the things that are happening and some of the things that need to happen so that you can start thinking about things you can do in your sphere. So defining access. To access healthcare, a patient needs 3 things in my gross overview of this: a provider, a healthcare provider who can take care of their needs, a place to go where they can get that healthcare, and a price that they can afford. They have to be able to financially access that. It doesn't do any good to have a great provider if you can't get there, if you can't afford it, and vice versa. So this all really came to a big head in my life when I was working a few years ago, and a gentleman came to our practice. He was middle-aged male. He had been there 1 year ago. He was back because it had been 1 year. He was out of refills. He needed his refills, and he was pale, and he was sweating, and he was short of breath, and his chest hurt, and he looked horrible. And I asked how long he had been feeling that way. Not an hour or a day or a week. He had been feeling that way for over a month. And I begged him to go to the emergency room, but he would not go. He hadn't come because of time and money. He was afraid of the high costs. He was afraid of what he might find out, and he couldn't afford to take off work. He worked full time. So here's someone who has a job, is trying hard to take care of themselves and their family, but still can't access health care. As I said, he would not go to the emergency room. I did see him a few months later, and he was looking pretty good because he had eventually made his way to the emergency room, had a triple bypass, and was now on government insurance. So I think that there could have been a safer and more cost-effective solution. So price is always the big issue when we talk about healthcare access. So who pays for healthcare? Medicaid is government insurance for the poor. Medicare, government-funded healthcare for people over 65 or with certain qualifying chronic medical conditions. Private insurance, sometimes employer subsidized if you're fortunate. Sometimes you buy it on the open market, but I'm sure that you know that even if you have insurance, it doesn't mean you can afford to use it depending on what your deductible is or what networks are available. So what is the gap? Just looking at Wayne County, total population 115,000. Of those, 94,500 under the age of 65, 12.2% of them have no insurance. So that's at least 11,000 people in our county who are uninsured. That's not taking into account anyone who's underinsured, Those are uninsured individuals. Very rarely will a child be in this count because of the Medicaid program, unless they're in an Amish or Mennonite congregation where they don't carry the insurance. So we're generally talking people ages 18 to 64. So why don't they have insurance? So unique to our community is the large population of the Amish and some of our Mennonite communities, people who are self-employed or who are small business owners, and the people who work for them. Work too much, make too little. So this is something that I've seen in person over and over and over again. I think of one patient I had who worked as a manager at a group home and worked her tail off. The people in those professions, if they stick around, work tirelessly, did not make much money, had 4 children and a husband she was caring for, got a raise of about $1 an hour and lost health insurance. So it was gone. And this happens again and again and again. People are punished for working more. And we've even had some patients who we've had to warn because they get excited because they might make a little more, be able to work more hours. But if you have a chronic health condition and you need medical supplies that are expensive, your health really depends on that access. And sometimes making a little more money, getting off government insurance could be really disastrous to your health and your finances. Ultimately, you're not going to be able to work. And then just simply not being able to provide private insurance, afford private insurance. So option 1 is to purchase the insurance, okay? Option 2, fortunately, we're in a great community that has some good community resources for some of the people in the gap, like the Startsman Clinic. But actually, part of my history, when I came back from BYU as an undergraduate, the semester when I had broken up with my boyfriend and my life was hopeless and I hadn't met Eric yet, I was an intern with the Startsman Clinic was Healthcare 2000 right before it opened. So I was there in the opening phases of that, which was exciting. Paying for your own visit, just paying out of pocket. Do nothing and wish for the best. And there's a lot of that goes on. So option 1, purchasing insurance, which seems like a rational thing to do. Looking at the numbers though, median household income in Wayne County last year, $56,000. And $25,000 is the average family of 4 could face more than that annually in premium and deductible costs, according to one report. So that would be a little less than 50% of their income potentially to get health care. And as you know, the remaining $25,000 isn't exactly sitting in their pocket. So option 2, community resources for people who qualify. And this is a very fortunate community. And there are options people have that just don't exist other places. So we're really grateful for that. Self-pay. Why not? It seems rational. Like, hey, I have a job, I'm sick, I go, I'll pay. So the problem with self-pay, one of them is the lack of transparency. If you want to be seen at a primary care office or a specialist's office and you say, hey, I don't have insurance, how much will my visit cost? You could just hear, sorry, you can't schedule with us because you don't have insurance, even if you're paying up front. But what I hear again and again, and when I was calling around, kind of putting feelers out when I was choosing my pricing, was it depends. And what it depends on is insurance. Even if you don't have insurance, your financial situation in the healthcare world is built around the insurance industry and its needs. So if I own a practice and I have contracts with an insurance company, they're not with my patients, they're with the insurance provider. So it's very company, not consumer centric. And what I charge you, my pricing structure is based on insurance requirements and the reimbursement rates. So a big part of this is billing for complexity. So when you come and see me and say I spend 15 minutes with you, your bill could be potentially $100 or potentially $250, even if I don't do a single procedure, order, that's not including the cost of any test. So we bill for complexity, which is the number of problems you have. So I get paid more if you have more problem. The number of parts we look at or talk about. So if I ask you just targeted questions about your respiratory system, that could maybe just be a level 3 visit. But if I ask you about your heart and your lungs and your head and your muscles and all that, and then prescriptions or treatments, the more I prescribe or the more interventions that are there, the more I can charge your insurance company. Now, if you don't have insurance, I still have to go by those guidelines, or that's insurance fraud. So literally, it does depend when you go in how much you're going to pay. Some places can get around giving a little bit of a self-pay discount for payment at the time of service, but your hands are really tied by these insurance contracts. And then more hidden costs with doing business with insurance companies. So there's all the administrative costs, you know, every medical practice, especially the bigger you get, you've got a lot of money tied in my mind, not to patient care, but into insurance care. Billing and coding, you're paying people to do that, and bartering and begging because they don't always pay. And I have insurance, I love insurance, I'm not anti-insurance. Andy, everyone, you're great. But it's a system that doesn't fit everyone's needs. So one example, prescriptions are a more transparent place we can get this example. So prescription costs, prior to being a nurse practitioner, I thought, you know, if I need to fill a prescription for an antibiotic, I could go to CVS or I could go to Rite Aid, and it's like the gas station. You know, there might be a few cents difference, but it is what it is. And it is farthest from the truth that you can imagine. So this is from GoodRx. You may have seen commercials, but it's a fantastic tool to help my patients find prices and prescriptions they can afford. So duloxetine, the first example, I have a lady who was on this. It's a type of antidepressant, but it's also used for chronic pain. It's been on the market for a while. It's a generic. Her insurance had paid for it for years. She used it to manage her fibromyalgia pain. And she came to see me and was just miserable. And I said, what happened? She said, well, my insurance stopped paying for the medication, and the pharmacy told me it would be $120. And I said, this can't be right. This is an old medication. It's a generic. I know that you can get it for less than that. So she was being charged the retail price of $120. But if you look through this GoodRx app, the prices you can get with it. So, sorry. Kroger, 1073, we don't have anyone around here. Usually your best cash prices in this area are Drug Mart and Walmart. So you could get it for $10 or $15 with their coupon. At CVS, you could get a discount only if you use this coupon and get it marked down to $51. So that's the difference between somebody being able to afford their medication and not, and potentially being able to work, and a big impact on their quality of life. Another one that I think is a pretty stark example is sildenafil, which is Viagra, which has recently gone generic, which was insanely expensive. So now at Giant Eagle, you could get 30 tablets, which I used to make the mistake. I had to say a 30-day supply, but I thought that's probably not the right way to go with this. We'll go with 30 tablets. So Giant Eagle, but if we go down to Wooster, so Drug Mart, $20.47, CVS, $346 for the same 30 tablets, and that's with a coupon. So we have to do better in being transparent and offering solutions to people. Otherwise, we can have all the resources in the world, but if people can't access them, their health still suffers. So option 4 is doing nothing. The benefits are you could get lucky, and the price is right if nothing goes wrong. Things could work out well. Risks, undiagnosed and untreated illness, no preventative care or screenings, and decreased quality of life. To me, that's really the bottom line in so many things. It's not about statistics or numbers, percentages of diseases, or it comes down to your quality of life. When I talk to people about smoking, I've smoked for years, that's what I push again and again and again. I'm not going to tell you about lung cancer. I'm not going to show you pictures of your lungs. I'm just going to say, this is what your quality of life is going to be if we can't get on another road. I've sat with people who are anxious all the time because they can't breathe. I've sat with people who are using inhalers 5-6 times a day. This isn't what we want for you. And that's what we really have to keep in mind, is the person and the family and what their life is going to look like if we can't come up with some innovative solutions. And what we're really competing against when we're looking at solutions is the choice to do nothing. Clayton Christensen, one of his books is called Competing Against Luck. And that's stayed with me a lot as I've gone through this process myself, is that we're not just trying to, like in my case, attract people to my practice, but I'm trying to convince someone that you can afford to take care of your health, that it's worth doing, you're worth taking care of. We're competing against the choice to do nothing, and you could say, and being comfortable, but really there's fear. There's so many things that are unknown about the system, especially if it's not something you've participated in traditionally. So I talked about price. The next thing is place, and there are a lot of great places. I think what a lot of them lack is being accessible physically. So obviously location or virtual hours are fantastic. I mean, that is one good thing from the aftermath of this COVID nightmare, is insurance companies and providers are more open to using virtual medicine, which is great. And one of my favorite applications of that is, I see a lot of people working in industry who not only is it inconvenient to get off work, a lot of times they just can't. They just simply can't. They don't have the luxury to, hop off to go to a Rotary meeting or take off an hour early or do anything like that. And the first time I did a telehealth with a guy who was at work in his safety gear, who had just been able to duck away to the break room for 15 minutes, I thought, this is a game changer. I mean, this is just huge. When you think diabetes, hypertension, depression, pain, all these things that I don't have to touch you to help you manage that. You need an exam at least once a year, but we can work on this. Truck drivers, I mean, that's just tremendous. And then along with that, convenient hours. So, we have a lot of convenient options for people for urgent care needs. And we have a couple of great urgent cares in this area, but that's not where you go for primary care. It's not where you go for primary care. Even if you go and your blood pressure is through the roof, they might give you, a month to get by, but they say you have to find yourself a primary care provider. You can't do this. And talking to people who've worked in a couple of different urgent cares in the area, talk about, we'll see these guys in industry who come in once or twice a year when they're deathly ill, but they need a lot more than that. So I think we have to be more open to creating our business models around the needs of consumers, not just our comfort or what's traditionally done. To only be open 8 to 5 Monday through Friday is pretty self-serving and short-sighted in my mind. We've got to come up with some other ways to do things. And then providers, a lot of it is a problem of supply and demand. Even if we had the right prices and the right places, we don't have enough people to take care of the need. And my focus is primary care because that's my background. And I shockingly am a huge proponent of nurse practitioners. And one of the big things NPs can do is increasing access to quality primary care. 234,000 nurse practitioners in the United States. A little education about nurse practitioners, because I know there's a wide range of knowledge. How many of you have seen a nurse practitioner before? Okay, so over half. Nurse practitioners are a branch of what are called advanced practice registered nurses. There are two types of APRNs. You have certified nurse midwives, you have nurse anesthetists, and then you have nurse practitioners. So you have to have a bachelor's in nursing, you work as a licensed registered nurse and have a work history there. Then you go to graduate school, a minimum of a master's degree. There's a growing DNP, Doctorate of Nursing Practice workforce. Then you have to have your clinical and academic training. You have to be board certified by a national credentialing body and then licensed by your state. My journey to being a nurse practitioner, because it kind of informs my view on healthcare and access. In the 1990s, I lived in the area, went to Triway, and I have this distinct memory of being in the choir room with a girl who was going to go to Akron and major in nursing. And I thought, but thank goodness did not think, like, why? Why would you want to go to school so that you could take orders from some doctor? And I just was like, yeah, that would be the end for me. And I still have no interest in taking orders from anyone, but I have grown a great deal of respect for the profession. I went to BYU, that's where I met my husband, Eric. That's the ex-boyfriend that I had just broken up with. I was upset about when I came and worked for Healthcare 2000. I went to BYU, graduated in community health and gerontology. We moved to DC and I worked for the Cancer Society. I realized there that so many of the things I wanted to do for people's health, you had to have a clinical background. And that when they told me in my undergraduate program I wasn't going to make money, that they meant it. And so I decided we've got to move on. When Eric went to law school, I went back to UVA and got a bachelor's in nursing. I graduated from honors. I worked, for 15 years, I worked in long-term care and rehab. I worked for 7 years in inpatient psychiatry, which was one of my great loves. And I worked in home health, but I felt like my hands are tied because I would see issues of access and there was not that much that I could do about it. I could give good care to the people that I was with, and obviously that was paramount, but I felt like there was more that could be done. So I went back to the University of Cincinnati. There's part of our crew. The day I graduated, worked for 3 years, as he said, in Canton at a family practice, and we served a large Medicaid population there. And I think that was really useful, first of all, as a human, to see all of the good people in the world who are doing their best or people that have had bad luck, but also seeing this is where the gap begins. You know, these are people who, but for the grace of God, you know, wouldn't have insurance, or if they worked a little harder, as we would say, could lose their insurance, and all of the health implications, especially when you consider the lack of preventative care. So what can NPs do? So I posed this to my Facebook crowd last night because I thought I might be making the wrong assumptions about what people know about nurse practitioners. And this is my friend Rachel. I'm working at a family practice that has 2 APRNs, advanced practice registered nurses, or NPs. And even though I've taken classes on different specialties, nurse practitioners were never discussed. I was surprised that an APRN can be a person's PCP, which is a primary care provider, and that a person can be confident that the APRN knows how to care for about any condition or problem that a traditional family doctor would handle. So that is what you get. This isn't a competition or ego thing. You know, we get asked frequently questions like, I got this one on Facebook: are nurse practitioners doctors? Asking for a friend who's a doctor, a juris doctor. No, nurse practitioners are not doctors, and that would be fine if we didn't live in a hierarchical society that sometimes treats NPs as a consolation prize when they're talking to their patients, and that's kind of garbage. Everyone in this society needs to do what they can to take care of people, and both disciplines have a lot to offer. And if we work together and collaborate, we can take care of a lot more people a lot more effectively. I was first introduced to nurse practitioners when I was at BYU at the Student Health Center. There was one, and I thought, who is this lady and what does she think she's doing? Like, this is odd. And then when I did my undergraduate degree, I had a professor who was a nurse practitioner who she was talking through a case that she had and someone she diagnosed. And I thought, my gosh, I've never had anyone ask me this many questions in this much detail. Maybe this is a profession I need to take a closer look at. And it's been a great journey. I've been really blessed, and I'm proud of what we have to offer. Other common questions? I don't know. That's all right. I'll tell you what's left on there. Is there? Try that one. Yep. Can nurse practitioners prescribe medication? Yes, this is my friend Cheryl said. The nurse practitioners at my practice seem to do it all. Appointments with them, they prescribe meds and order tests. They seem to do it all. So we do diagnose conditions, we do order treatments, tests, and prescribe medication. Do nurse practitioners work under doctors? It depends. The scope of practice varies from state to state, and that's what our role is defined as from a legal sense. So this is from the Institute of Medicine. They did a lot of work with the Robert Wood Johnson Foundation around 2010, looking at healthcare needs in this country and how to solve it, and saw NPs and increased collaboration with other medical professions as a big part of that. So nurses have the opportunity to play a central role in transforming the healthcare system to create a more accessible, high quality, and value-driven environment for patients. If the system is to capitalize on this opportunity, however, the constraints of outdated policies, regulations, and cultural barriers, including those related to scope of practice, will have to be lifted, most notably for advanced practice registered nurses. If the vision that the Affordable Care Act put forward, which was kind of the spring for this, is to come to pass, and people are going to have access, we have to transform this profession and lift some of the practice barriers. So it varies from state to state what you can do. The IOM report said that nurses should practice to the full extent of their education and training. This is the American Academy of Nurse Practitioners practice map. Full practice in the green states. And, it's kind of interesting, this swath of states here that's green, a lot of the progress started in places like Minnesota and Montana and North Dakota, where the population is small and there's such a large rural community. They had such a hard time getting providers out there. Ohio, we're in the yellow zone. And if you look at the Future for Nursing campaign, said that what they track is progress on the removal of statutory barriers that prevent nurse practitioners from providing care to the full extent of their education and training, thus helping increase consumers' access to care. And Ohio's progress is incremental, which is a smidge above nothing. But it's better than nothing. So Ohio's Nurse Practice Act, as it now exists, does not now allow nurse practitioners to practice to the full extent of their training. And the result is decreased access to healthcare for vulnerable populations. So you may ask why that's a problem, and I'm just going to tell briefly my story to give you an example of how I opened my clinic with the view that everyone deserves access to high quality healthcare they can afford. And I was going to focus on cost, my location and hours, and being NP-led, being a nurse practitioner-led clinic. And it was the clinic that almost never came to pass because of the elusive collaborating physician. So it sounds like a great idea to someone that every nurse practitioner has a collaborating physician who looks over her from their throne of greatness and makes sure that she doesn't plague society in any horrific way that they could prevent. And when I went to school and I heard all this push about nurse practitioners, full practice authority, I thought, why do I care? I just want to go take care of my patients. Like, I really, really don't care. And I don't from an ego perspective, but what I found in practice is that you have primary care nurse practitioners who can't find jobs in primary care. When you go to do something in Ohio, like open a clinic by yourself, not only is it not done, you have to find a collaborating physician. And a lot of the arguments for that are patient safety, patient safety, patient safety, patient outcomes. However, this is what a collaborating physician has to do in the state of Ohio. They have to sign a collaborative agreement that you write that says when you can reach them if you have questions, that says you won't practice beyond that which you've been trained and licensed to practice. It says that once a year they will randomly review your charts, and that twice a year they will randomly look at your prescribing patterns. And then you let them know if there are any medications you want to use off-label, okay? So if that were it and it were that easy and you had a bunch of people signed up who wanted to do this job, I don't think you'd hear that much from people. It's annoying, but finding someone to do this is really, really difficult. Some of them work places who don't allow moonlighting at all. Some of them are afraid of liability, even though that's statistically unfounded, it's still your license. If you find someone who's going to do it, which took an act of God on my part, you still have to pay them to do it. And then you have to pay your insurance company more than twice of what I would pay for just myself and my practice to have them covered in an administrative capacity. And so this rubs me the wrong way because there are people that could be helped and we're shutting the doors to that. You have nurse practitioners who will go to rural underserved areas, who will go to inner cities, who will help populations that are being underserved, but their hands are tied in our current practice environment in this state. So my solution, I said, my clinic's affordable healthcare partners, but it's built on the principle of NP-led care. I'm doing self-pay because that way, if I cut insurance companies out, I can tell everyone this is how much it costs, period. No hidden costs. You pay me when you get there. And then I'm open evenings and weekends. So this is not the only solution, but it's an example of how I think we need to think outside the box and where we need innovation and more ideas. And I challenge all of us, I guess, when we look around at these social issues, how you can be part of the solution. If anyone wants to email me, I can send you some of the data from the Institutes of Medicine, some of these other reports that are interesting. And then the website, the campaignforaction.org, shows you where things are now and where they're headed. So thank you.
We have time for maybe one question. Does anybody have a question for Krista here? Maybe Zoom land, any questions? Doug, I know you have a question, don't you? Okay, no questions. Ted, you have a question? No? Okay. What happened to the Browns? Back to reality. D?
Do you have any association like the AMA that protects your rights as a nurse practitioner?
That's a great question. You have the some national bodies, AANP, American Association of Nurse Practitioners, that provide some help. A lot of the barriers, though, like when you look at legislation that's been before the Ohio House, most of the pushback comes from physician groups, unfortunately. It's not from patient advocacy groups, but it's from physician groups. A lot of them have been really resistant. And only about 50% of physicians from some of the study I've read are on board with the idea of nurses having full practice authority. So, and their jobs aren't going anywhere. Nobody wants to get rid of doctors. Like doctors are fantastic, but we just need to work together.
Thank you, Krista. Krista, thanks again. We've got a homemade rendition of our Rotary wheel. It's got the 4-way test on the back, and it's made by the Village Network.
Thank you very much
again for being here. We appreciate it. And great presentation. Well, extremely well done. I did notice one thing, Eric. She was saying that she doesn't take any direction from anybody, and you said yes. And that was about the time she had the photo of the ex-boyfriend that was on the cliff. So if you're not in good graces and she's like, let's go out to Colorado, I would maybe not go. No, I'm out. Yeah, there we go. Look at my double chin. That's always great. So we appreciate you being here today. We had about 30 on Zoom. We had about 35 people here. So we're holding our numbers nice and steady. Samara sent me a note to kind of remind you that we are looking to potentially get back to the church at the end of November. So we will continue to watch that. But for right now, we'll be right here at Greystone. Next week, Doug, you've got a great presentation for us lined up on basically is solar energy what it's all cracked up to be. So I know there's made some advancements there. So RSVP for that. There's a number of opportunities for you to volunteer your time for the Rotary programs throughout the month of November. You'll get an email on Wednesday. Make sure you sign up if you have time. Folks, we stand adjourned. Have a good rest of the week.